My name is Christopher Crane. I'm the gastrointestinal section leader in the Department of Radiation Oncology at Memorial Sloan Kettering. First of all, metastatic anal cancer is fairly uncommon compared to other malignancies because anal cancer is a fairly localized disease most of the time. There can be synchronous or metachronous metastases. Patients with metachronous metastases tend to have a better prognosis, and we've certainly been able to control those, and some patients do have oligometastatic disease. We approach the treatment of the metastatic disease the same with the same doses that we would to the primary disease. So while we may consider 10 gray times 5 or so to be an ablative dose for most solid tumors, even slightly less than that can be considered ablative in anal cancer. However, there is usually room in the liver or lung to give a higher dose if and I end up giving that 10 gray times 5 typically, or 8 gray times 5 in metastatic anal cancer. If there are nodes that are, say, for instance, in the periortics or portohepatus area, that can be considered, while technically that's M1 disease, I think the staging system would probably be better if that were classified as N2 disease, because patients with periortic lymph nodes are very curable. We published that 20 years ago. So I just consider that the next echelon of nodes from the pelvis and treat that with curative intent. And it's sort of unfortunate that that's called M1 disease, because I think people may be tricked into thinking that it's not curable when it's extremely curable. It's as curable as anyone with advanced pelvic nodal presentation. We published another series of patients who had been apparently cured of oligometastatic disease, and most of those cases were metachronous treatments. When I became less selective about treating metastatic disease and started treating the patients with synchronous presentations at the same time as treatment of their primary, we found that we weren't as successful. So certainly when there's synchronous metastatic presentation, that's a reflection of very bad biology. We do tend to still recommend treatment of the primary and the nodes, only because it can be done, and some of these patients probably do have oligometastatic disease, but that's been a poor prognostic feature. Since we're treating the primary in our normal fractionation, we can take more fractions to treat the metastatic disease if desired, but trying to achieve a bioequivalent dose of 80 gray or more should be the goal. So for instance, we don't really change the regimen very much. If a patient has METs at presentation, we would still stick with the same regimen that we would use in patients with localized disease, and give concurrent chemotherapy with it.